So can I ask a either Socratic or betraying of my ignorance question then?
Sure.
So once upon a time, it seemed like DBT was specified for a target population. Now it's obviously, you're saying it could be characterized as a certain kind of behavior therapy. Is it characterized as having a target population of any sort of breadth or
when the treatment was developed, it was developed for chronically suicidal women. So if there's one group that I would say for sure is chronically suicidal women, and we really have seen no difference in its responsiveness with men, and when you bring the age down, I mean, I don't have empirical data for that, because of course we don't have trials for that, but it's pretty clear for the suicidal population that DBT has something other things don't. There have been trials for binge eating and bulimia without borderline personality disorder. There's trials for elderly depressed people with access 2 disorders that have shown some benefit, but it's really spotty what there's actual RCT data for. What I usually tell people, and I'll come back to this, is if it's pervasive emotional dysregulation, I think you're in the right place. If the pervasive dysregulation is causing impulsive behavior that essentially drives everyone bananas, then you're probably in the right place.
Okay, that's what I was curious.
But stop doing it for like every mild population in the world is usually, that's the thing where it usually drives me crazy. Or doing it for other disorders where there are clear alternative interventions, which like schizophrenia, like one more person says they want to do this for schizophrenia without like any discussion of any DBPs for schizophrenia, that drives me nuts. Yes.
Having spent a lot of time with Marcia in the last month, she's saying pretty publicly now the sort of surprising view of some of her pre-analysis that's looking like the skills part is really the key part. And as you know, because we've been doing real life DBT in our programs for years and years and years, and we've had a skills group for years and years and years. And since I'm not on the DBT team, but I'm a doctor that treats a ton of other patients, and I encourage lots of my other patients who have impulse control or skill deficit kinds of behavior around managing all kinds of emotional dysregulation things. And those are people who have schizophrenia, schizoaffective, bipolars, all kinds of different people. And I've been saying for years that I think this skills stuff really works very well, because it's not like I'm sitting on the back of an RCT. I'm sitting on the back of real life people getting real life treatment, and I'm seeing them over years. And I'm hearing them 5 years later saying, well, in my DBT class, so that the patient, it seems to stick with the patients. And so my kind of view about some of the central elements of DBT are that, if you do the whole Shinola, it should probably be aimed at highly cost, high problematic, multi-problem, suicidal people like that. But the skills element seems to have a much broader application. It's obviously got a much easier application, although as you stated, Kate, I think that whoever does it has to know what they're doing.
Right. I think that's the thing that, like, what Rick is alluding to is in the preliminary data, we've only got people through the end of treatment in this component analysis, not the follow-up. But the preliminary analysis looks like the skills are more important than we thought, because her first trial of skills showed zero effect, like totally zero effect. And so this seems to go differently. The two things that I would say are different is, one is we're using the new skills that she's not yet got out in print, so they're better. So it could be that. I don't know if that's true, but I really do think they're better skills. They're not that different, but there's some new skills that, boy, our patients, we're a pilot site for the new skills, and boy, some of the new ones the patients love. And also that it's being done by people who are really adherent to how to do a group, and that's what's true at Harborview. We've got one of our DBT clinicians doing the group, and I think if you know how to do the group, it makes a huge difference. But it is one of the things that we've been looking at, is that is skills plus intensive case management sufficient, or do you really have to have the clinician know DBT? My clinical opinion is there's a lot of behavioral control you can get the suicidal behavior to stop you can get the general absolutely nutsy behavior to stop with skills plus time-scheduled case management, really sufficient availability that people can actually get to their case manager without having to be in crisis. You know, that's always been my experience from training, and I think that's what this data may be bearing out. We'll see when we have the full data set. You never know once you get all the data analyzed. Sometimes the preliminary results aren't what you expect. But yeah, I think that's a key thing.
I think what's reassuring to me around treatments is to have some evidence base, but to also have this kind of real life over years kind of talking to real patients over time. I feel more comfortable about knowing something's going to work when I'm informed by both.
Yes.
Because we have too many evidence-based treatments that just don't work in the real world or seem to work somewhere but not others. So I like both kinds of information.
Yeah, and there's actually we just did for our grant proposal, we pulled together all the non-randomized pre-post and non-controlled trials, and there's actually quite a fair number of studies outside of the lab and outside of sort of RCT research that support using DBT. But I didn't talk about data today because that would take too long. So let's talk about DBT targets. So this is something that I think is unique to DBT, and it makes a huge, huge difference. So the thing in DBT is that we have a very specific target hierarchy. So there's also a stage system that has to do with how out of control someone is, but let's just presume, as Rick is saying, that you only want to do DBT with people who are behaviorally out of control. I don't know that we have any data for doing it with more stable patients. I think there's a lot of other interventions for stable patients that are cheaper, and most of the time you guys, the people you're getting asked about are out of control people, not in control people. So let's just look at the behavioral control stage. So the goal in this stage 1 is to get the person into behavioral control. And there's a very, very set hierarchy. You always have to prioritize treatment in terms of suicidal behavior, treatment interfering behavior, quality of life interfering behavior, and skills. And then you can get to any other personal projects that the client has that they want to work on that isn't included in that. And so this is a very set hierarchy. It creates control at a chaos. I cannot tell you how critical it is when you have a patient coming in with 12 problems to be able to figure out what to do. I won't go through the details of it, but even within these targets, there are sub-targeting. So even if you kid coming in or an adult coming in with 8 times of suicidal behavior, there's not even a hierarchy for that. So like if you've got multiple suicidal behavior on your hands, which one do you tackle first? It's critical from my point of view that we're tackling treatment interfering behavior second. If you've got these kind of extreme and complex cases, it's really important that if the treatment itself is not working, if you and the patient interacting in a talk therapy is not functioning, that's the highest target other than them being dead. Because otherwise, the analogy I typically use is as if you're trying to build something and you have one of those drill screwdrivers, and so you're trying to get all the screws in, put this piece of furniture together, or put up this wall, or whatever it is, and then the machine breaks, right? And what I see people do is it's essentially like they're using the drill as a hand screwdriver, right? It is not working very well, and the piece of furniture are getting pretty darn frustrated, right? Just like they and the client are getting really frustrated. It's going to happen, probably slowly, if you don't give up. But it'd be a lot better to stop and fix the darn machine and then go on, right? So that's the first. Fix the therapy first and then try to do the therapy. And I think that's something that was very unique for me at least in learning DBT. I think it's pretty unique from other interventions and makes all the difference in the world. So these are all the different behaviors in DBT that we directly treat as our second highest target. The other thing that's the equally high second highest target is therapist therapy interfering behavior. So in DBT, it's equally important that you're treating anything the therapist is doing that interferes. So there are things that show lack of respect to the client, like not being there for your sessions, or having to leave halfway through, or taking pages, or things like this, which are not unusual in especially residential or other kind of chaotic settings. I was just trying